wherever you are. My name is Samuel Jinja. I am a research associate in behavior analysis at the School of Psychology at Ulster University in Coleraine, Northern Ireland. And today I will be chairing this presentation as well as presenting together with Annie Galdos from Cantor Azul in Mexico and Catalina Herrera from CTA in Colombia. This presentation will take around 1 hour, including some time for questions at the end. You will be muted throughout the presentation, but you are welcome to use the Q&A function throughout the session to ask any questions, although we'll probably leave those to the end. So the session will be recorded and available later this week, reviewing. So without further ado, I'll start. And I also would like to add that I would encourage anyone to ask questions if you have them. So hopefully this will work well. Okay, so why is the slide not moving? Okay, let me just try. Okay, right. So the title of this presentation is "What does behavioral science have to do with safe water interventions? The role of behavior analysis in the SAFEWATER project." And before I talk about behavior analysis and the SAFEWATER project in more detail, I'd like to start by talking about the water, sanitation, and hygiene problem, or WASH, as it is usually known as. And access to water, sanitation, and sanitation have been declared as human rights by the United Nations. And that means that everyone should have access to sufficient, safe, acceptable, physically accessible, and affordable water for personal and domestic use. And the same applies to sanitation conditions. The reality is that 4.2 billion people still lack safe sanitation, and at least 2 billion people use water that is fecally contaminated. And that is responsible for diarrheal disease, which, as this graph shows in the blue area, kills over 500,000 children under the age of 5 each year. When we look at the reasons for this number, we see that unsafe water sources are the #1 reason. And this diagram shows the different paths of fecal to oral contamination and how feces contaminate water as well as hands, and how they can end up in our organism one way or the other and cause illness. So interventions can try to address either of these 3 routes or more than one. So it's either sanitation, hand washing, or safe water. And some interventions that have addressed one or more have achieved some success and were able to decrease diarrheal disease. However, there are many remaining challenges. And in the case of safe water interventions, for example, only 27% of studies have reported a high sustained use of point of water treatment at the last recorded follow-up. That means that in more than 2/3 of the cases, people are no longer treating water as they should a few months after the research. And this is particularly concerning if we consider that decreasing these good practices by as little as 10% reduces health gains by up to 96%. So in other words, if we want to improve health, people need to drink safe water in a very, very consistent way. And we can think about water treatment happening at the source, so in a more centralized way, or more individually at a household level. And treatment at the source means that the water is being treated by someone else, that households don't need to do much, and many of us are fortunate to be in that position. But treatment at the source also requires a certain level of investments, of organization and commitment in the community that may not always be possible in some contexts. And even if the source is what is known as an improved water source, the problem is that they are not always safe, whether that is because of unsafe pipes that distribute the water to the households, or unsafe storage at home, or simply because they are not consistently used by people. And for that reason, water treatment in the household is still preferred and promoted in many cases. And similarly, there are technologies that have the potential to improve health, but often fail to do so, as this photo illustrates, because they are misused or not used enough. For that reason, there is increasing recognition of the fact that safe behaviors must be adopted and maintained over time in any kind of wash intervention, if we are to achieve meaningful health improvements. So the SAFEWATER project is a collaboration between Ulster University in Northern Ireland and partners in Colombia, Mexico, and Brazil. So in Mexico, so we have the University of Medellin in Colombia, we have the University of Sao Paulo in Brazil, and we have two NGOs, Cántaro Azul in Mexico and the Centro de Ciencia y Tecnología de Antioquia, or CTA, in Colombia. The project is funded by the Global Challenges Research Fund and the UK Research and Innovation Fund. And the aim of SAFEWATER is to develop and implement low-cost safe water technologies in rural communities in Mexico and Colombia. In Mexico, those communities are indigenous communities located in the southern state of Chiapas. In Colombia, they are located in the region of Antioquia, near Medellin. And I'm not an engineer, and I have not been involved in the design or development of the systems, but hopefully I can give you a rough idea of how they work and what they look like. So there's a lower tank that's where the untreated water goes, or the raw water as it is known locally. Then that untreated water goes through a filtration system and the UV lamp for disinfection, and it is there then pumped to an upper tank that contains the treated water. And again, then goes through pipes to the taps in the household. Pardon me. So people don't have to do much to use the systems other than opening a tap. But they may have to fetch water if they have no piped water at home, and they will have to do some maintenance, such as cleaning tanks and filters every now and then. And SAFEWATER has people from different disciplines working together. Behavior analysis, we work particularly closely with colleagues from nutrition, who will be looking at the impacts of the project on health outcomes, particularly in children. And the role of behavior analysis is to work with the local partners, that is the NGOs in Mexico and Colombia, in the assessments and intervention on behaviors that are relevant to the project. I should also say that the NGOs, Cántaro Azul and CTA, are the ones who will be doing the field work. And behavior analysis as a science aims to understand the behavior of individuals. And by behavior, I mean everything that we do. Whether that is something that other people can see, such as drinking, eating, talking, or something that only us can experience, such as feeling and thinking, whether it's something simple, such as walking, or more complex, such as solving a complex mathematical equation or treating water. And it's something that we're doing continuously. So behavioral interventions will aim either to increase certain behaviors, make them more frequent, or to decrease them. And so at the start of a behavioral program, some of the questions that we need to ask are, first, what are those behaviors of interest, and how are we going to define them in clear terms? Then we need to ask, and how are we going to assess them or to measure them? And then we can ask, and what are we going to do to change them, to either increase them or to decrease them? And there are a number of behaviors interests in the SAFEWATER project. And the more precise we can be about them, the easier the assessments will be. So for example, you can imagine that with systems like this at home, we want people to use the system. That's a very obvious one. We want people to open the taps of the system for drinking, for hygiene, for cooking purposes. We want people to look after the systems according to our instructions, to clean tanks and filters, fixing and replacing pieces, or contacting a technical team if they have one. So these are things that we want to see happening more during this project. On the other hand, we don't want them to open the tank that contains the treated water without a good reason, because that can lead to recontamination. We want them to carry safe water when they go outside, for example, to the field. We don't want them to store water at home because that can easily lead to recontamination. So we want them to drink directly from the taps of the system because that's the safest source for them. We don't want them to drink untreated water. And we want them to wash hands with soap at critical times before eating, after using the bathroom. And there are different ways of assessing behavior, all with pros and cons. One of the difficulties of measuring behavior is that when people know that they are being monitored, that they often change their behavior or report it differently. In this project, we have considered and tested different methods and decided that a mix of self-reports, that is asking questions, and observation checkpoints in the household worked best for us through monthly visits to the household. And I should say at this point, like many other projects, the pandemic has delayed our work significantly, and we have not yet been able to start the field trials that we are planning to test the systems. However, prior to that, we had done some preparation field work to develop materials and procedures for the main trial, both related to the assessment of behaviors and health outcomes. And the aim was, from a behavioral perspective, to identify some of those behaviors that we might target in the future and to understand the conditions in which they happen, and also test the feasibility of procedures to assess them, and also more generally procedures such as the recruitment of families, how to seek consent from participants, and other practicalities. We conducted a series of small feasibility studies since 2018. We followed a cross-sectional design and relied on convenient samples using questionnaires and direct observation. And so first, in Mexico, this was an area of considerable socioeconomic deprivation, in fact, one of the poorest in the country. We visited 20 households. Of these, almost half participants could not read or write. It was predominantly an agricultural environment. Less than half of the households had a functional toilet or latrine. And some households had piped water, although it was not always reliable. Other households would rely on rain water, and others on wells, and many would rely on more than one source. And those sources were usually not safe for consumption. So the water would have to be treated before it could be safely used, and usually boiled. Although some households were happy to drink it untreated, or raw, as they call it. We also visited a few households that had a SAFEWATER technology called Mesita Azul, which is a piece of technology that has been designed and developed by Cántaro Azul. and which involves a disinfection process with a UV lamp, which has some similarities with our newly developed system. It is a very functional piece of technology, very user-friendly, very appropriate to that context, but which still requires special care. And what you can see in these photos down here are some of the practices that are required to use the Mesitasol, which involve disinfecting with chlorine and washing thoroughly the containers in which the disinfected water is going to be stored. So this is necessary every time the tool is used in order to prevent the recontamination. And so in SAFEWATER, we wanted to reduce the need for these actions to happen as much as possible. And we wanted to make the water treatment process easier for the users. Then in Colombia, we found a very different population. We've also visited about 20 households. Here, nearly everyone was able to read or write. There were fewer people in the household on average, and everyone had a functional toilet. Everyone also had piped water, although again, that water was not safe for consumption. It would have to be treated, usually boiled, before it could be used safely. And we also tested the feasibility of some procedures, having in view the main trial. And so we're thinking whether we could something like this, in this case, it's an automated photographic camera. We're thinking whether it could something like this, the main trial, for example, to assess in a more objective way how people use the system. And we were able to observe some interesting issues at the time, such as this child who came from school and went to get some water that his grandmother had boiled earlier that day by dipping a cup and then leaving the cup floating in the pan. And there was no evidence that the child had washed hands either. So as you can see, there are many issues that need to be addressed to prevent the recontamination of water and make these household water treatment methods effective. There were difficulties with the camera. It was something time consuming. We had to visit households more than once a day. And during these visits, we also conducted structured observations where we had two observers spending some time in the household with the families to observe their routines around water and hygiene. We were able to observe the water boiling process and identify a few issues, such as the fact that the water was not always covered afterwards, or that people would dip in a cup for drinking, like the child on the photo. And this procedure too was challenging because it takes time, and houses were often small, and it was not possible to observe people from a good angle at all times. So based on this information, we refined our assessments and observation tools, and we went back to Mexico and Colombia more recently, before the pandemic started. And this time we visited specifically a few households where the systems are currently being piloted. So that is before the main trials and before the systems are implemented in other households. And so the main trials will be carried out to measure the impact of the systems of the projects on health outcomes and behavioral outcomes. And these will be carried out by the NGOs, Cantero Azul and CTA. We will use for this multiple baseline design or stepped wedge design, where different groups, and that can be different communities or different parts of a community, will receive the intervention at different times. This also makes it more manageable for those installing the systems. So these are just hypothetical graphs here. So we could have something like this for each behavior. So let's imagine the percentage of households who report drinking safe water every day. So we'd start with a period of baseline. So that is the period of assessment before the intervention starts. And while some people will be in the intervention phase already, others would still be in the baseline phase. And it is this difference in timings that provides the control data in this case, the term of comparison. In addition to these, we will also have a pure control community in Colombia. So that is a community that will not receive the systems, although we do plan to carry out some activities with them at the end of the project. When we talk about intervention in safe water, we mean the systems that have been developed, but also other strategies of behavior change that we want to put in place to complement that. And we want to do this in a way that addresses the issues that are specific to each household. That's what we mean by data-driven. It is possible that in a household, the main problem is the storage of the water for drinking, whereas in another, it is the inadequate washing of the tanks. So different strategies would be needed for each household. We have a number of possible strategies that we might use at the household and community level, although that will also depend on COVID-19 restrictions that might be in place at the time. And before I talk about the behavioral intervention plans in more detail, I'd like to go back to the question of what behavior is. And as we all know, behavior is a very complex matter. Behaviors differ widely in their form and in their causes, but they also have common elements. And in behavior analysis, to understand behavior, we try to understand the causes of behavior by looking at the circumstances in which it occurs. We call them the antecedents because they occur before behavior. And we also pay special attention to the consequences of behavior. So that is, what happens when people do X or Y? What is it that they get out of those actions that they wouldn't get otherwise? This analysis does not make behavior less complex, but it helps understand and deal with that complexity. And we know that behaviors are followed by consequences, and those consequences are very important for people to continue engaging in those behaviors. So for example, when we drink untreated water, it may be that we're thirsty and we are somewhere where only untreated water is promptly available. So those are the antecedents. And in this context, the behavior of drinking untreated water becomes more likely to happen. And the natural consequence is that we quench thirst and can proceed normally with our daily activities. But by drinking untreated water, there's also another practical value, which is that we save time and effort, and money and effort in the case of boiling, and we avoid the hassles that boiling entails. And this is especially relevant in a context where there is a little money or little fuel, which might be needed for other things. So the other possible consequence for drinking untreated water, of course, is illness, but that might take hours or days until it happens, or it may only happen sometimes, not always. And is that weak connection between the behavior and the consequences that can make a difference. And it also makes it more likely that people will not see the connection between their actions and their consequences, and they'll be more likely to attribute those consequences of that illness not to their actions, but to something else. And this issue of immediate or delayed consequences and of continuous or intermittent consequences is very important to understand behavior. Unfortunately, many behaviors that are detrimental to our health or to the environment have an immediate gratification, which has a very powerful effect on what we do. Whether that's the convenience of driving a car and getting to places quicker, or the taste of some foods, or partying with friends and having fun, even if it is during a pandemic. On the other hand, for behaviors that are good for us, it is not very obvious what the immediate benefits are. So whether it's going for a walk or a run, or wearing a face mask all day, or boiling the water and disinfecting the water containers all the time. So there's no immediate gratification for doing those things. And it isn't clear what the benefits are, especially when the benefits are to avoid something that cannot be seen, such as viruses or bacteria. So our role as behavior change agents is to remind people of those invisible and delayed dangers. For example, by showing them what the germs in the water that they drink look like, and give them more information in other ways. And also stress the benefits of that their healthy actions will have on that. And then thinking about antecedents and consequences, so thinking about how we can change their environment, their antecedents, by, for example, providing them some materials such as soap or a bottle and encourage them to use them, and changing their home environments in other ways, for example, with clear instructions on what needs to be done uh, and how should the systems be used and when, with plenty of pictures so that it's very easy to understand. We also want to demonstrate to people how the system should be used and get them to practice while we're there, and hopefully train both adults and children. And then we want to reinforce those good practices by providing some more immediate consequences. So when people engage in the right behaviors, such as praising them, show them, for example, how their household is doing on a particular issue or behavior, how they have progressed over time, uh, and show them the results of water quality tests that from water that we have collected from their household that show that their actions are having an impact on the quality of their water. For example, the actions of looking after the systems and washing them properly. So this will give people a sense that there is a purpose in what they do. And we should do this both when there is an issue with the water, but also when the water is safe, so that people can see that their actions are paying off. And at a more community level, we also need to identify key people in the community that can act as role models and can encourage others to keep up with the good work, and people that can help and organize the community in a way so that they fundraise, perhaps with monthly contributions or with more other activities, but fundraise for the sustenance of the systems in the long term. And this can be, for example, with fun activities that involve interactions with others. So these are some of the strategies that we plan to implement, still under discussion with the NGOs and subject to local needs and preferences. Hopefully this has given you an overview of what we do in the behavior analysis team as part of the SAFEWATER project. I am now handing over to Annie Galdos from Cantera Azul in Mexico. Annie, over to you.
Thank you, Samuel. Okay. Well, let me introduce a little bit myself. My name is Annie Galdos Balsategui. I lead the knowledge management unit in Cantera Azul for 5 years, and now I'm leading the SAFEWATER project. My background is in environmental science and public health, so I have a multidisciplinary, and it's focused in water, sanitation, and hygiene. Well, Samuel has already explained much of the work that we have been doing and we will be doing on the SAFEWATER project. I would like to share a little more about the learning in the process of designing wash intervention with an impact on behavior change. Next, please. Yeah. Cantera Azul has 14 years of experience designing, implementing, and evaluating water sanitation and hygiene solutions in school households. And in the SAFEWATER project in Mexico, we will carry out in Los Altos region, as Samuel commented, where Cantera Azul has been working since 2013. Next one, please. Well, there's a great evidence and knowledge about the behaviors associated with the lack of safe water and the lack of adequate hygiene and sanitation conditions that pose a risk to health. As Samuel showed in his presentation, the pathways in which humans can come into contact with fecal contamination are well known. So we can observe these behaviors and identify those that should be modified to improve people's health. And this is what we see, and it is what we measure to assess whether our intervention have any impact on changing such behaviors. In the field of behavior change sector, it's really wide. There are many experiences and interventions that have been designed around the world, and also many learnings about them. But before designing interventions, it's really important to understand the causes, what Samuel also called the antecedents of these behaviors, and that is everything that we don't see. And there are a large number of determinants that influence or can influence these behaviors, some of them individual, environmental, and in environmental with the more next, like from the settings to a more structural determinants. And as a researcher, to begin to understand these causes, to ask ourselves why and why to everything that we see, you know. So that is why formative research, it is so important to be able to design and redesign the interventions and improve our actions one and again and again. So it is a cyclical process. Also, as a researcher, I believe that it's very, very important to reflect on our situated. It is sometimes difficult to understand some behaviors when we have not been exposed to certain realities. So it is important not to judge behaviors and rather to understand that there is always an explanation for each of them. Sometimes easy to understand and other times really complicated to understand. Um, in countries and contexts where access to safe water is not a problem, uh, we don't see it as a risk to our health, and neither is much time spent on water management at the household level. So now, I would like you, I would like to ask you some questions. How many of you know where the water that you consume in your household comes from? Or how many of you know the process that water has to go through until it reaches your tap? Or what would happen if one day water stopped coming up from the tap, or if you no longer trust the quality of the tap water? And imagine that now someone tells you that from now on you must treat the water in your home every day. So do not drink water from unsafe water source. And if these messages come outside from our culture, from people who speak another language, who don't know how you live and sometimes judge it. So these type of questions help to begin to understand why people have the behavior. Next one, please. Now, I'm going to name, I cannot see the next slide, I'm not sure. Well, now I'm going to name some behaviors that we have observed that can influence the quality of water and therefore put people's health at risk. And while I'm naming them, I will invite you to think about why these.
Sorry, just having some difficulty in moving the slides here, Annie. If you.
Okay, a little bit because the images are important.
Right. Let me try to stop sharing. Let's see. Okay. Let me share again. Okay, can you see again, or it's and back to the same, isn't it?
Yeah, it's the same one. I can see it, but it should be the next one.
No, I understand. Try again. Sorry, this kind of things happen sometimes when these kind of events.
It's okay.
Oh dear. So let me try again now. Okay. So Okay. Can you see this now, Annie?
Yeah.
Okay.
Yeah, this is the next one. Okay. Okay, so let's, next one. Yeah, let's first look at the hygiene settings. Before that, yeah. Well, here we are not observing behaviors, but rather we are observing checkpoints. But even so, from these images, we can know some of the practices, such as, for example, unsafe water storage, or we can observe animals there that are near the water and that can be a focus of recontamination, source of contamination. So the other behavior that I would like to the use of multiple water sources. Households use an average of 2 or 3 different water sources to supply themselves throughout the year. And the practice of fetching water is really common. The next one, please. In the next slide, we can observe, I cannot say it well.
Okay, I think we're having a bit of a technical issue here again. Right, I'm gonna have to keep sharing and presenting. Okay.
Okay, yeah, in this slide, practices related to drinking water. There are all images of containers that people told us they use for drinking water. We see, well, the most common practice for water treatment, that is boiling water. We also see direct consumption from the tap with untreated water. We can see water stored in an unsafe way, the introduction of other contaminants in water to serve it, and we also see something that looks like water with high turbidity here in the top. Actually, that's pozol. It's a typical drink in the region made from corn. And well, in Los Altos, they normally don't drink just water, they drink pozol. So this is something really important to understand and know. Next one, please. We have learned over the years that it's important that interventions have at least 3 components. One is associated with facilitating access. We must facilitate access, make it easy, and make it the simplest and the most satisfactory choice. For the safe water intervention, we specifically design a system adapted to this reality that I was describing in the images. Its objective is to give access to a minimum of 50 liters per person per day established by the human right to water. And we wanted to work in communities where the use of multiple sources of water is necessary and facilitate the safe storage of water and its distribution to the points of the household where the water is used. We also want it to be easy to use and attractive. Um, Another component is the participation. We must involve people in the process since they are the ones who are going to make these changes. Therefore, they must be part of the solution as well. For, um, for access to water to become a continuous service, there needs to be an organized structure that maintains the systems. And this is why it is important to involve community authorities. And finally, another component that I called communication could be awareness, but has to do with all the other activities that are associated with providing information, knowledge, with the aim of changing beliefs or changing some social norms, for example. And to explain this, I will give you an example in next slide, please. We know that one of the reasons why people drink contaminated water is that they don't believe that there is a risk on it. So Well, we carry out water quality testing as part of our activities in our assessments. And over time, we have realized that people in the community were very curious about it. Next one. What we had tried to communicate with talks and workshops was much better understood with water quality testing methods. In this way, we changed our intervention from being one where the risk of contamination of water were communicated to one where the community was invited to participate in the testing and monitoring of water quality, and where they were invited also to see the invisible life of water with tools such as microscopes. The next one. Well, I would like to end my talk by saying that learning, it is continuous. At this time, for example, in SAFEWATER project, we have a new question that we must answer in order to add something to the design that we are not sure if it would be added to the technology component or the communication component. And I will explain briefly. The management of the storage, treatment, and distribution of water in the household is so complicated that normally the treated water is used only for drinking and in some cases for cooking. And as I was saying, we want to guarantee at least the 50 liters per person per day established by the Human Right to Water. And we have 3 prototypes of these systems in different households. We place also water flow meters in the system to know the daily water consumption in each of them. And well, our surprise is that families are not using the amount of water we expected. They continue to use the system only for drinking water and for cooking. And so we were asking ourselves, why is this happening? And we have several hypotheses. It can be because they value the treated water so much that they don't want to waste it, or that they have heard the message that treated water is just for drinking so many times that they do not use it for anything else, or that they cannot see how much water they are using because it's now in a closed tank and they are afraid of wasting all the water, or it is just because the water scarcity. We don't really know right now. We need to continue understanding more and go into the field and talk with people and see what is happening. So that's why I was saying the design are always getting better, and for that we need a lot of formative research. And yeah, I think that was all my talk. Thank you.
Thank you, Annie. And now over to Catalina.
Hey, good afternoon. Are you here?
Yes, I can hear you.
Okay,
Not very well.
Okay, I'm environmental engineer, magister in education and human development. I am part of the SAFEWATER research team, working also with Centro de Ciencia y Tecnología de Antioquia, Antioquia Science and Center and Technology Center, CTA. I'm sorry for my English. I'm not good at English speaking, but I'm going to do my best. I hope you understand me the most. Okay, Samuel, can you please the next slide? Yes. Okay, my presentation is an approach to work on behavior change and social appropriation of technology in 2 Colombian communities where we are implementing the SAFEWATER project. I want to give you a contextualization. Colombia is a very complex country from every point of view, and in relation to water, it's a country with a great water wealth, but despite this, there are gaps in relation to the availability of water for the population, especially in rural areas. For example, we have an aqueduct coverage of around 97% in urban areas and about 73% in rural areas. But this doesn't mean that there is potable water. The gap is much greater in access to drinking water. Drinking water coverage in urban areas is close to 90%, but in rural areas, it is only about 26%. In the case of SAFEWATER projects, the two communities where we work with have water, one of them by aqueduct, but other by a hose from the stream to their house, and in neither cases is potable water. These communities, before slide, okay, thank you, Sam. These communities use this water for various uses, for domestic affairs, for domestic animals, for their crops. They use eventually rainwater, but especially surface water sources that is transported by aqueducts, pumping, or water hose. And it's usually that they collect and store water in domestic containers. And since they don't have access to drinking water, the treatment that all households do is to boil the water for the consumption. Now, in relation for the hygiene habits, in these communities, there is no open defecation. All households, despite their low income, have sanitary facilities such as a toilet and a bathroom sink. But although there is a hand washing after using the bathroom, in few cases, they don't wash their hands with soap because they don't have soap in the bathroom sink. Next. All this that I have just told you is part of that diagnosis that we have made of the communities, and that has allowed us to identify activities in places such as the kitchen, the bathroom, the house in general, and at schools, because we are also going to install a safe water system in them, which imply a risk of contamination and on which we want to influence through behavior change strategies. Once this diagnosis has been made, these hygiene practices that imply risk have been identified, we return to what the WASH approach and behavior change propose, and it's to understand that behavioral changes require interventions at a physical level, in our case, the technology of drinking water from SAFEWATER, at the cognitive level, and at the social and motivational level, which implies providing relevant information on motivators and well-defined strategies. These make us to do some questions like, what are the key targets groups? Which are the drivers of change? Which key messages are necessary, and what are the communication channels for them? As well as the identification of emotional motivators, such as children's health, for example, behavioral and environmental factors that allow the elimination of barriers and promote these changes in behaviors. Thus, we understood that in our case, the success of the project will be around the empowerment and social appropriation of technology of the SAFEWATER system, changes in hygiene habits in the uses, and in changes in the uses of water. So we prioritize some behaviors that we want to influence, and we define an educommunication strategy around those behaviors related to the appropriation of the system, with the use and maintenance of the system, and with water uses and hygiene habits at homes and also at school. For each behavior, we define the target audience and educational strategy, sometimes supported by educational material. For example, in the case of the social appropriation of the system, we want people to be able to organize as a community to maintain the system over time after the project ends, because What often happens with these types of projects is that when they finish and people have to put up money to make an arrangement to fix the system, since if they are not organized and didn't have an economic plan to assume this, and also they hope that the state or the sponsor of the project be eternally responsible for the project, then they stop using the system and go back to consuming unsafe water. Therefore, we want to bet on promoting this social organization and also influence in financial saving behaviors that allow this sustainability over time of the safe water system. For this, we have proposed strategies such as workshops and financial savings, incentive games, and others. In the use, operation, and maintenance of the system, the strategies are very focused on training and signals in the technology, in the system. In the next slide, Samuel, please. And in the case of homes and the school, the behaviors to influence are focused on the habits of hands washing, both in the preparation of food as well as before eating and after using the bathroom. Also in the way they store water. And all of these through workshops, games, education material, and also with signals. Next. Okay. Now, as the Antioquia Science and Technology Center, CTA, we have opted for the social appropriation of technology and social innovation as strategies through which the communities participate in the use of the technology and even in its construction. At CTA, we understand the social appropriation of science, technology, and innovation as an intentional process between various stakeholders who actively participate in the exchange, reflection, production, dialogue, and validation of knowledge, motivated by interests of use, application, and enrichment of knowledge contextualized in their different cultural horizons for the social and economic benefit of a region. In the case of SAFEWATER, we are observing, for example, that there are modifications that they make inadvertently to the system that have given way to rethinking technical uses. For example, like you can see in the photo, in one of the communities where we had pilots, the treated water in the tank was being heated by the sun, and what a man of the community did was cover it with a mesh to reduce the exposure to the sun. This means that, for example, that the technical team is considering in this moment changing the color of the tank to reduce its heating. This is then a form of social innovation where communities influence technological solutions, get involved, and we believe that is how appropriation is achieved and contributes to the sustainability of a project like SAFEWATER. Okay, thank you. This is our strategy for the change behaviors in these two communities in Colombia, and we are working on that in this moment.
Okay, thank you, Catalina. So we have now some time for questions, if there are any. So I'm going to open the Q&A here. So I don't see any questions here, so feel free to ask anything or say anything. Oh. Hello, can you see me? Hi. So I was saying that we now have some time for questions. If you'd like to say or ask anything. And we welcome anything. So I liked, Catalina, the example of the water, of the covering it to make it cooler. I think it's a good example of doing something that brings an advantage, in this case, having the water cooler for consumption. What are your experiences and expectations with SAFEWATER? Do you think that could be something that we could see happening a lot, people making small tweaks like that to make them more useful or more convenient? Anya, Catalina, any thoughts on this or any experience?
Sorry, Samuel, can you repeat me the question, please?
Yes, so I was asking about, that adaptation of the users covering the tanks. Do you think that's the kind of thing that will happen a lot in SAFEWATER? You think that others will do similar things or other things?
Well, can I say something? I will expect to see those kind of adaptations to the system. We have seen that in different systems, especially the ones that are at the household level, because you will have a lot of different experiences, because we will have like in Mexico, around 200 households with these systems. So we will expect to see that. We have seen it with the Mesita Azul, we have seen it with the ceramic filters, and it depends on sometimes just the beliefs of that they need to do something, and especially in for example, in communities that are organized and the communication is really like happens in all the community. We start seeing the same adaptation to all the household in the community. So we'll expect to see that, and we'll see.
Yes, it's the same case in Colombia. We hope that the communities can contribute and do some changes in the technology if it's necessary, and we want to record all these changes like an innovation, social innovation of the technology.
Okay, thank you.
Okay.
Oh, sorry. Okay. So we have a few questions. Okay, right. Thank you, Catalina. We have a few questions here now from the audience. So first question, great presentations. What is the source of power for the system to pump the water into the upper tank? So this is a very technical question, which is well beyond my domain of expertise. So I don't know if perhaps Annie or Catalina could answer this. I'm not sure. We can find out and then share these answers at the end. Annie, any idea of the power?
Yeah, sorry, I was on mute. Can you repeat the question? I cannot read it.
What is the source? Oh, sorry. What is the source of power? It's the source of power, sorry, for the system to pump the water into the upper tank. So I guess.
Okay. Well, I don't have the technical information. We are using a pump. Well, the system is treated. Well, we already said, no, with filters, we has a pre-treatment with filters and USE. I don't know the technical specification of the pump. If that was, if I'm not sure if you were talking about electricity. If they
think
need
so. I'm not
electricity.
entirely sure. But it is. But the households have electricity in both Mexico and Colombia.
They do have. We have 7 of them with that they are not connecting to the electricity, but we will give them solar panels to be able to to pump the water and treat it with the UV system.
Okay, all right, thank you. So hopefully that will answer. So the next question is, were there different reactions to the programs at the introduction in the
Samuel, but sorry, Samuel, but the power of the
Yes. Oh, okay. Catalina?
of the pump, the power of the pump is 12 volts, but in all the cases we need electricity, but it's a little power. So we think that, for example, the electricity that they use for boil water is less or similar like the electricity that the pump needs in the system. 12 volts. I don't know how to say volts in English. Volts. I think yes.
Okay, thank you, Catalina. So next question, were there different reactions to the program at the introduction in the two different countries expected? I'm not entirely sure what is meant here, but in general, there are differences and very important differences between the two contexts. And I guess this means differences in the people, in the population, and as we've tried to describe, they're very different socio-demographically in terms of their practices. And I don't know whether there is something more specific here that
I would like to respond something to that. Yes. The contexts are really different. In Mexico, we are talking about a rural area where people do not have pipe water, and they do need to fetch the water and use multiple sources. And in Colombia, in these communities, they do have pipe water. Also, even if both are rural communities in Mexico, they are indigenous communities. And the way, I mean, also the architecture of the household are different. So what they see at the end as the service, it is different in one and the other. I mean, we are giving, in Mexico, they will see tap water where they were, and before the intervention, there was not any tap at the household. And in Colombia, they will see more like the treatment of the water that was already given by a tap. So there are quite some differences, and related to the more pedagogical or more communication strategies, where we are adapting those to the context also. So the program has some adaptations to feed in each context. No? So yeah, we expect to have different reactions also.
Okay, thank you, Annie. Hopefully we have answered. Okay. So the next question is, hello, many thanks for your presentation and talks. For your observation studies, is it possible to observe users without informing them about the project? And how can the privacy issues be solved when observing people? So as far as I'm aware, that is not happening. That may happen somewhere, but in our project, that never happened, and I don't think it is going to happen. People will have to give their full informed consent to take part and to be observed. And for example, in the small studies that we've conducted, I show that photographic camera and also the household observations. People were informed and were asked their permission to take part, and were happy to take part, to agree, to give consent. And in the case of those photographs, for example, just to give you an idea, we followed an existing ethics protocol, and we asked people, we first consulted people about where in the kitchen that the camera would be placed. And we gave them the freedom to cover it at any time if they wanted with a cloth. And then at the end of the day, we went there, we downloaded all the pictures, and there were hundreds of them, if not thousands, and we would have to go through all of them, and people would have the choice to delete any that they wouldn't they didn't like it. So it is a very, very complete process that involves people at all stages with their consent and their awareness. Hopefully this answers. We have another question. How long will the main intervention run for? Are there plans to conduct activities over the intervention period to reinforce the behavior in case of relapse? So that's a good question. We were planning for a 12-month period. Now, as I said, we have suffered a considerable delay. As far as I know, we're still aiming for that, although possibly with some constraints. We have plans to address behavior and behavioral issues during that period. Then after that, at the moment, we're trying to have an extension, something that would allow us to go back and see how things were going then. But we're still working on that. So I don't know if Annie or Catalina would like to say something about this.
Well, you already said we are not sure about the length of the study right now, but even if we have thought about some interventions, we still think that we can introduce new ones once we start understanding which kind of reinforcement they will need, for example. Here the difficulty is that we're also analyzing and studying the health impact. So we need to understand very well which is the intervention that we are doing, so we don't I mean, so we can do both studies at the same time and not difficulting one to the other. I don't know if I'm explaining myself, but I guess, Samuel, I don't know if you agree, but we were thinking about these changes or introducing some that need them.
Yes, yes. Sorry, I think I lost you there, but I agree with that. So yeah, things are still shaping up at the moment. Okay. Well, we've run out of time now. So if there's any questions, I guess you can still ask them by email. I would be happy to answer. So I'd like to thank everyone very much for attending today, for your time. I hope you enjoyed this presentation, and thank the panel as well, Annie and Catalina, and Maria for her technical support. And apologies for the technical issues, but these things happen. So hopefully we'll meet again soon here or elsewhere. So to you all, have a good day. Thank you.